Hi, I'm Dr. Nada Albatish. Welcome to Opening Video in Restorative Dentistry. The thing about the vertical dimension is that when we're in school, we're all taught that it's this sacred concept that we don't touch. And we all come out of school with this artificial belief that if we do anything about changing the vertical dimension, we're probably going to mess up our patient. And what I'm here to talk to you about today is why sometimes you need to consider opening a patient's video. This is exactly why we need to consider opening a patient's video. This is a patient that walked into my practice earlier this year who had had a bridge done from tooth number 8 to tooth number 13 only a few years ago. And because of the patient's deep bite and because of the patient's wear and forces on the teeth in the direction that the patient's moving, both teeth that were abutments for that bridge fractured. This is exactly the patient who would benefit from opening the video. So why would we open a patient's video? There are several really good reasons to do that. The first and most common reason in restorative dentistry is to create room for restorative materials. And this is really common in patients that have wear across their arches. Patients with existing vertical collapse also can benefit from opening video. Patients who need bite improvements or improvements in aesthetics. Just think about it. If when a patient smiles or when a patient is at rest, you can barely see any of their teeth, that's a patient who you really could benefit from opening the vertical so you can add more tooth structure so you can see it and make them look nicer. Another reason is to preserve tooth structure. The way to think about that is if your patient had let's say your patient had 2 millimeters of wear and now you wanted to crown 8 front teeth. If you were going to do that and just drill 2 millimeters into the teeth, you might end up in a situation where you're right into the pulps of those teeth. But if you add 2 millimeters of restorative material by opening the video, then literally you would not do any incisal reductions on those teeth. So you're really doing a big favor to your patient by preserving their tooth structure. And one thing that I've seen in my practice is that by opening vertical, you can improve the patient's joint condition. And a really simple way to think about this is picture patients with complete upper and complete lower dentures. Now in your mind, take the dentures out and have the patient close all the way down. Picture the joints, what's happening. They're closing, closing, closing to where the teeth should have been, and then they're over closing until your patient is really gumming it. And that is a patient who could really benefit from opening the vertical dimension to get the joint back into a better position. And you can think about that more gradually in patients with, let's say, 30% wear. They're overclosed and you open them back up and you get a patient whose joint condition is improved with an open vertical. And I'll show you an example of that later in this presentation. This is an example of a patient who benefited from opening vertical by us needing to create space for restorative material, and also opening vertical benefited this patient by helping me to preserve tooth structure. I'm going to show you another example here of another patient with less wear, and I'll talk to you about now the options for lengthening these teeth. The options are, number 1, crown lengthening and endo. That's pretty invasive. Number 2, opening the vertical dimension, and like I explained earlier, that means we can just add restorative material without cutting back tooth structure, so we're also preserving tooth structure. And the third option is orthodontics to intrude the teeth, or orthognathic surgery to intrude the entire maxilla. And for this patient, that was a no-go. Number 3 was not an option. So the best and most beneficial treatment for this person was opening the video. What is challenging about opening video? The first thing is, how do you know how much to open? How do you know you're not causing your patient harm? How will you communicate the new video to the lab? And why is written communication to the lab about the new video that you want to establish not enough? I'm going to address these points so that they are no longer challenging to you. The key is to make it predictable. So I'm going to share with you now a predictable technique for opening video in restorative dentistry. The first and most important step in this procedure and in every procedure you do in dentistry is knowing where you are so you can get to where you want to be. This really is all about diagnosis. Step 1, determine the existing video. This is really a simple baseline. I just measure CEJ to CEJ. And I like to use a digital caliper to do this because I love to be accurate. Step 2, now we want to determine what the video should be. And there's 2 ways to do this, and I combine them both. The first step is looking at average CEJ to CEJ measurements. A normal class 1 patient is about 16 to 18 millimeters CEJ to CEJ. A normal class 2 patient is 14 to 16 millimeters, and a normal class 3 patient is 18 to 21 millimeters. You don't have to have these numbers memorized. Just have it written somewhere in your operatory or somewhere in your practice so that you can refer to these numbers to know where your patient lies compared to the normal range. The next step to figuring out how much or where we want the right video to be for this patient is an aesthetic evaluation. Look at where the central incisors are in the face, look at where the canines are in the face, and always remember a very important point: lengthening the teeth alone without making a change to vertical dimension will deepen the patient's bite. Why is a deepened bite a problem? Picture this. You have a patient that's got 2 millimeters of overbite. The teeth are short. They look kind of squared. You want to lengthen them 2 more millimeters. So let's go ahead and do that. Lengthen them 2 more millimeters. What we've now created for this patient is somebody who has more tooth structure to pass as they're trying to move. We are restricting their movement. We can actually undo this by, when we want to add 2 millimeters to the length of the teeth, if we open the bite by 2 millimeters, they cancel each other out and you haven't actually restricted their movement at all. Normally, if you want to lengthen all the teeth in an arch, or 8 or 10 teeth in an arch, you need to open the video. This is an example of an aesthetic evaluation for a 38-year-old female patient. Looking at this patient, she looks completely edentulous. You can't see the teeth at all in her rest position. This is one of my favorite photos for doing aesthetic evaluations. I always, always, always measure the incisal edge position, because when you look at the previous slide here and you don't see teeth, you don't actually know where the teeth are and you don't know how much you need to lengthen those teeth. So by putting a ruler in and measuring where the incisal edge position is relative to the lip line, we can actually tell how much we're going to need to lengthen those teeth to get them into the smile zone. I'll show you more on this case later. The next step, once you've figured out how much you want to open, is to visualize the end point with the correct tooth proportions. The entire point of this step is for you to look at the teeth and imagine them, or use a computer or use an iPad to look at those teeth and figure out if they look right. You can also do the measurements of the vertical and the horizontal and make sure that your central incisors are 75 to 80% height to width ratio. The next step is to open the video pre-operatively. So let's go back to this patient that we initially measured the video. The CEJ to CEJ measurement was initially about 15 millimeters. I determined that I wanted to open this patient I wanted to lengthen those teeth 2 millimeters, and I wanted to open the patient's bite 2 millimeters so I don't restrict their function. A very simple way to do this is to use a leaf gauge. 10 leaves equals 1 millimeter. 20 leaves equals 2 millimeters in the front. So I open this leaf gauge to 2 millimeters, which is 20 leaves, put it in the front, have the patient slide forward and back, and squeeze as though they're squeezing on their back teeth, and inject some bite registration material there. You'll notice that at this step, I also use digital calipers to measure my opening. So here, the CEJ to CEJ measurement is 17 millimeters. And if you compare that to the beginning, when the patient started at 15, we know that we've opened the video 2 millimeters. The next step that I do in my practice is to test the joint at the new video. For this, I use a joint vibration analysis. In this patient's joint vibration analysis, if you look at the pink lines, so there are 2 pink lines. One is the right joint and one is the left joint on the top graph, and the same on the bottom graph. At the beginning, when the patient is biting on her baseline and we do her JVA, she opens and closes, and you can see the pink line showing all kinds of vibrations in the right and left joints. When we opened her vertical dimension only 2 millimeters to the height we wanted the patient to be at, that joint vibration analysis became quiet. That pink line became flat. And that means that the joint actually quieted down. The clicks actually went away and the joints are now at a better condition. So I know before I ever treat this patient that the video that I've selected for the patient will actually improve this patient's joint condition. The next step is to take a bite registration at the planned restorative video. We initially put in a leaf gauge and we took the bite registrations in the back. I love to use the Futar D material by Kettenbach because it's a really solid, hard material. It is not spongy. So when we take these kind of bite registrations, they're really accurate and the models sit in one position. So we took the 2 bites on the right and left side in the back and we had the leaf gauge in the front. I would take the leaf gauge out of the front and now put more bite registration into the front to create 3 pieces. We call a tripod. And a tripod bite makes it easy for your lab technician to mount accurately so that the models are not tilting when they're mounting the case on an articulator. And now a common question that I get about why would you even want to do this? Why do you want a bite registration at the video that you're at the open video and not just at the patient's original starting position? Why would we want to mount using the restorative video? Research shows us that opening the pin on an articulator actually introduces errors. And the reason for that is when we open the pin on an articulator, we're doing this on a machine. When a patient opens their mouth, the articulator does not 100% represent human biology. So if we want to open the pin on the articulator, it is less accurate and introduces error as compared to just taking your bite registration at the restorative video. And that way when your lab technician mounts the case at the restorative video and waxes it up there, you completely eliminate the error introduced by moving the pin around. I'd like to review with you now the summary of steps to open video. Determine the existing video by measuring CEJ to CEJ. Determine what the video should be, looking at known values and doing your aesthetic evaluation on your individual patient. Visualize the endpoint. Make sure the teeth look right. Open the video preoperatively with a leaf gauge. Test the joint position at the restorative video. Take a bite registration at the restorative video for lab communication. Always remember that accuracy in treatment planning equals predictable treatment. This is a patient that I showed you earlier that looked edentulous because there was no teeth showing in the at-rest photo. After doing the aesthetic evaluation and opening the bite so that I'm not restricting the motion of my patient, this is what the patient looked like. This is another patient that I showed you earlier today that had a worn dentition. I treated this patient by opening the vertical dimension of occlusion. The benefit to this patient was preserving tooth structure because the entire procedure was really additive and not restricting the patient in his new motion. So as you can see, there are a lot of elements to consider when you want to open a patient's video. And I look forward to exploring with you in the future when, where, why, and how much to open video.